Hello everyone, welcome back to the channel Therapeutic Guideline by Kurat Atif. So today we will be covering chapter number 3 and 4, overview of common drugs used in dentistry, and a few pages of chapter number 5, which will be antimicrobial drugs used in dentistry. So if you are preparing for exams, working in practice, or simply want to refresh your knowledge, this channel will make your journey easier and more enjoyable. So don't just watch, subscribe now and share this channel with your friends, colleagues, and study groups because the more we grow, the more content I'll be able to bring you. Let's make learning smarter, faster, and stress-free together. All right, so start with the overview of common drugs used in dentistry. So the common drugs which are used in dentistry, these guidelines include practical information on using the following drugs in dentistry: antimicrobial drugs, analgesics, corticosteroids, mouthwashes and other topical formulations, local anesthesias, and anxiolytic drugs. Now, for comprehensive drug information, including precautions, contraindication, adverse effects, and drug interactions, consult an appropriate drug information resource. If prescribing a drug for a dental indication, consider the balance of benefits and harms of the drug in the individual patient. This requires knowledge of the patient's medical and medication history, including prescription, over the counter, and complementary medicine. Now, sources of drug information for dentists. Sources of drug information include services, journals, books, electronic resources, and websites. Medicine information services are available to support specific queries about medicine. For example, you can see via the Directory of Medicine Information Services from Advanced Pharmacy Australia, which may only be available in certain jurisdiction or health services. Or also you can see the Australian Dental Association website or other private providers. Now about the journals. Australian Dental Journal, ADJ, can be accessed via the Australian Dental Association website or Australian Prescriber, which can be accessed online. You also have books and electronic resources. So Australian Medicine Handbook, it is an evidence-based medicine information, also includes drug interactions, calculator, and average weight and height for children. It can be accessed via the ADA website. Therapeutic guidelines, a source of independent and practical treatment advice for a wide range of clinical conditions. There is one more book, OzDI. It is a comprehensive medicines database that includes independent drug monographs, product summaries, and pharmaceutical company information, and can also be accessed via Australian Dental Association website. There is one more book which is quite popular here, is MIMS. It contains product information as provided by pharmaceutical companies and approved by the Australian Therapeutic Good Administration, TGA, with additional features to support medicine choice and usage. It is available by subscription from the MIMS website, including MIMS Drug for Dent. Drugs and Lactation Database, LectMed. It contains information on excretion of drugs into breast milk and their possible effects on a breastfeeding infant. It is available from the National Institute of Health website. Any recent textbook on clinical pharmacology and therapeutics. There are a few websites they have given, which is Pharmaceutical Benefit Scheme, PBS, and Australian Dental Association. So these 2 pages conclude our 2 chapters, which is chapter number 3 and 4 of revised TG, which is showing like online. Now let's go with the chapter number 5 of therapeutic guideline. It is antimicrobial drugs used in dentistry. Okay, so this is chapter number 5. And in this chapter, we will explore how to choose the right antibiotic for the right infection. We'll also understand resistance patterns, and we'll also learn safe prescribing practices to ensure the best patient outcomes. All right. So, overview of the principle of appropriate antimicrobial prescribing in dental practice. This topic include this topic outlines the principle of appropriate antimicrobial use for prophylactic, empirical, and directed therapy in dental practice. More detailed advice for medical practitioners is available in the antibiotic guideline. Appropriate antimicrobial therapy improves patient outcomes, reduces unnecessary antimicrobial use, and reduces adverse consequences for the patient and the community. Appropriate antimicrobial prescribing include the following steps. We have to decide whether antimicrobial therapy is indicated, considering the balance of benefits and harms of antimicrobial therapy, including direct and indirect adverse effects. We also need to consider whether antimicrobial therapy is prophylactic, empirical, or directed. Collect samples for microbiological testing if possible, for example, when draining pus in a spreading odontogenic infection. For details on sample collection, we will see spreading odontogenic infections without severe local or systemic features in upcoming chapters. Select an appropriate antimicrobial agent for the indication. Select an appropriate antimicrobial regimen considering their dose, the frequency, route, in children, palatability, and availability of an appropriate formulation. We need to prescribe the shortest possible duration of therapy, taking into consideration the condition being treated and the patient's clinical response. Document the prescribed antimicrobial therapy in the patient's medical record or medication chart, including the dose, indication, and the intended duration of therapy before further review or stopping therapy. So we need to record each and everything in patient's file, so it's very important. Principles of prophylactic antimicrobial therapy in dental practice. Prophylactic antimicrobial therapy aims to prevent infection when there is a significant clinical risk of infection developing. It's not developed yet, but it is developing. However, antimicrobial prophylaxis is usually not required for common dental procedures. So when we'll read antibiotic prophylaxis for dental procedure, we will learn more about this. Okay. Now, principles of empirical antimicrobial therapy in dental practice. So, empirical antimicrobial therapy is used to treat an established infection when the pathogen has not been identified. So, infection is already there, but we don't know the pathogen yet. Antimicrobial choice is based on the clinical presentation and the expected antimicrobial susceptibility of the most likely or important pathogens. Empirical therapy is reasonable in the following circumstances. When treatment must be started before the result of culture or susceptibility testing are available. When the infection is not serious enough to warrant taking samples for culture. And if a sample for culture cannot be obtained. In these three cases, we use empirical antimicrobial therapy. Now, review empirical therapy as soon as possible. In hospital patients, therapy should be reviewed daily. If the diagnosis excludes infection, we need to stop antimicrobial therapy. If a pathogen is not identified, we reevaluate the clinical and microbial justification for therapy. If ongoing therapy is indicated, we consider de-escalation. For example, de-escalation means change parenteral therapy to oral therapy, or change a broad spectrum to a narrow spectrum antimicrobial therapy. Okay. Now, if the pathogen is identified, then we follow the principle of directed antimicrobial therapy in dental practice. Now, what are the principles of directed antimicrobial therapy in dental practice? Directed antimicrobial therapy is used to treat an established infection when the pathogen has been identified. So now you can see all three different kinds of therapies. First, we learned about this prophylactic antimicrobial when there is a significant clinical risk of infection developing. It's not developed, but there is a risk of infection. Then we learned about empirical, which means that infection has been established, but the pathogen has not been identified. And now we are learning about directed antimicrobial, which means that the infection has been established and pathogen has been identified. So directed antimicrobial therapy is used to treat an established infection when the pathogen has been identified and an antimicrobial with activity against the pathogen can be selected. Now, preliminary microbiology results, for example, gram stains, may allow targeting of antimicrobial therapy before definitive results are available, modify ongoing therapy once the pathogen and susceptibility are known. Selecting an appropriate antimicrobial in dental practice. To select the most appropriate antimicrobial for empirical antimicrobial therapy in general dental practice, factors to consider include the required spectrum of activity using the narrowest spectrum therapy required. So first of all, we need to use the narrowest spectrum therapy. Then we need to consider potential adverse effect of the antimicrobial, drug interactions. Then patient factors comes, including patient preference, whether the patient has a history of antimicrobial hypersensitivity, whether the patient is pregnant or breastfeeding, whether the patient has a condition that alters pharmacokinetics, for example, kidney impairment, cirrhosis, whether a suitable formulation is available of that antibiotic, or antimicrobial availability. Antimicrobial stewardship principles also we need to consider. Choosing a suitable route of administration for antimicrobials in dental practice. Now, oral and enteral route of administration for antimicrobial in dental practice. For most infections, oral antimicrobial therapy is appropriate. Intravenous therapy may be required under specific circumstances. What are those circumstances? We will read it later. If oral therapy is used, ensure that the patient can tolerate the antimicrobial and has reliable gastrointestinal absorption. We also need to ensure that the selected antimicrobial is appropriate for the indication. It has adequate tissue penetration at the infection site, and it has good bioavailability. Now, there is a box I'm going to read which says examples of antimicrobials used in dental practice with good oral bioavailability in adults. So, what is bioavailability? Bioavailability is the fraction of an administered drug that is absorbed into a system circulation in an uncharged form. This figure should not be extrapolated to children, as bioavailability of antimicrobials in children differs from adults. Okay? Now, there are the following examples are antimicrobial that have oral bioavailability over 90% at standard oral dosing. First, doxycycline, and the second one is metronidazole. So these two have oral bioavailability over 90% at standard oral dosing. And the following examples are antimicrobial that have oral bioavailability between 50 and 90%, which is amoxicillin plus clavulinate, which is, I think, clindamycin. No, amoxicillin plus clavulinate is augmentin, cephalexin, and clindamycin. So these antimicrobials may be given orally rather than parenterally. However, intravenous therapy is still required in patients with severe infection or where the chosen antimicrobial does not have adequate tissue penetration at the infection site. Now, for children who are unable to swallow tablets, the availability of a suitable drug formulation can affect antimicrobial choice. So, the Australian Medicine Handbook Children Dosing Companion includes for information about the administration of medicine to children, including information about palatability. To enable administration in children, it may be possible to crush or disperse oral solid dose formulation of antimicrobial. Consideration include the suitability of the oral solid dose formulation for crushing or dispersing. See the Don't Rush to Crush handbook. So, this book, Don't Rush to Crush, is available for purchase from the Advanced Pharmacy Australia website or through a subscription to eMIMS Plus. Okay. Now, we also have to consider the ability of carers to perform preparation steps. Also, need to consider patient acceptability. For example, taste. If the oral route is unsuitable, the enteral route, for example, nasogastric, nasoenteric, percutaneous endoscopic gastrostomy may be used. So there are different routes. If oral is unsuitable, we can use all these. The enteral one, no, nasoenteric, and PEG. Okay. Now, intravenous route of administration for antimicrobials to treat oral and dental infections. Intravenous antimicrobial administration is required to treat oral and dental infections when urgent treatment is required for severe and rapidly progressing infection, when higher doses than can be administered or tolerated orally are required to achieve an effective concentration at the site of infection, when oral administration is not tolerated or not possible, or when gastrointestinal absorption is likely to be significantly reduced. For example, if patient has a vomiting or gastrointestinal pathology, and if there is no oral antimicrobial with a suitable spectrum of activity. So only in this conditions we can consider for intravenous route of administration. Okay. Now, other routes of administration for antimicrobial in dental practice. Topical administration of antibacterial is associated with the emergence of resistant organism and can cause hypersensitivity reactions. So there is one more route of administration which is topical. Topical antifungals are used in the treatment of infections such as oral and oropharyngeal candidiasis. So, for more information on candidiasis, we will see oral and oropharyngeal infection caused by candida and related species in later on chapters. Inappropriate use of topical antifungals may contribute to antifungal resistance. All right. Okay. Next topic, choosing the duration of antimicrobial therapy in dental practice. Advice on duration is included in the clinical topics in these guidelines. The duration of therapy for some indications is based on clinical practice and experience because it is not clearly defined from published studies. In general, use the shortest possible duration of therapy, taking into consideration the condition being treated and the patient's clinical response. If antibiotic therapy is necessary for dental infection, a short duration is usually sufficient because the key component of management is a dental procedure. For example, oral regimen of up to 5 days are appropriate for non-severe spreading odontogenic infection without severe local or systemic features or necrotizing gingivitis. However, there are certain indications that require prolonged therapy. For example, mandibular osteomyelitis. So TG is saying that if the patient has a spreading odontogenic infection, but there are no severe local or systemic features, we can go for up to 5 days. But if they have more, they require more prolonged therapy in case of mandibular osteomyelitis. So, prolonged duration of antimicrobial therapy is associated with direct and indirect adverse effects, including gastrointestinal symptoms, rash, life threatening hypersensitivity reaction, Clostridioides difficile, formerly known as Clostridium difficile infection, infection caused by Candida and related species, selection of antibiotic resistant organism, and of course, increased cost. Okay, so our next topic is antimicrobial stewardship, AMS, in dental practice. What is antimicrobial steward in dental practice? Antimicrobial stewardship promotes optimal microbial prescribing. AMS program aim to improve patient outcomes and reduce adverse consequences associated with antimicrobial use, including antimicrobial resistance, toxicity, and unnecessary cost. AMS is an important strategy for preserving the effectiveness of available antimicrobials in the face of rising antimicrobial resistance. Evidence shows that AMS activities can reduce inappropriate antimicrobial use and it also improves patients' care. The priority antimicrobial list for antimicrobial resistance containment document was developed by the Australian Commission on Safety and Quality in Healthcare. It categorizes antimicrobial that have high resistance potential. Consideration should be given to restricting these antimicrobial at an institutional level. The Australian Antimicrobial Stewardship Clinical Care Standard describes standards for safe, high quality care of any person who receive antimicrobial therapy. The ACAS QHC, which is the Australian Commission on Safety and Quality in Healthcare, they also publishes antimicrobial stewardship in Australian healthcare. The AMS book provide information that informs AMS strategies across different healthcare settings. In Australia, national safety and quality standards require all hospitals to have an effective antimicrobial stewardship program in place, which is assessed for accreditation. For a comprehensive discussion of antimicrobial stewardship program in hospitals, see AMS in hospital in the antibiotic guideline. Older people, especially those living in residential aged care facilities, have increased susceptibility to infection due to physiological changes that occurs with aging. There are high rates of antimicrobial use in residential aged care facilities. The rate of antimicrobial resistance is higher in residential aged care facilities than in hospital. For a comprehensive discussion of antimicrobial resistance in residential aged care, we can see AMS in residential aged care facilities. Most antimicrobial use occurs in the community center settings, so general dental practice is an important focus for antimicrobial stewardship. AMS strategies can have a major impact on population wide antimicrobial consumption. Community based dental practitioners can have a positive influence on the beliefs of patients and the broader community about antimicrobial use and resistance. And for patient resources, see AMS resources for patients in the antibiotic guideline. The Australian Commission on Safety and Quality in Healthcare is developing AMS strategies to optimize antimicrobial prescribing in general practice. Many of these strategies can be applied in dental settings, including strategies for primary health networks, general dental practitioners, and other staffs. Now, there is a table which says antimicrobial stewardship strategies for general dental practice. Um, it's not important as exam point of view, so I'll skip that table. And okay, our next topic is antimicrobial hypersensitivity in dental practice. Introduction to antimicrobial hypersensitivity in dental practice. This topic includes information for dental practitioner on taking a clinical history to assess patients who report antimicrobial hypersensitivity. It also include implications of the clinical history of a reaction to an antimicrobial, and it include assessing and managing patients with penicillin hypersensitivity. More comprehensive topics on antimicrobial hypersensitivity for non-dental practitioners are included in the antibiotic guidelines. Information in the antibiotic guidelines that may be useful to dental practitioners include an overview of antimicrobial hypersensitivity, including common misconception about antimicrobial allergy and definition of commonly used antimicrobial hypersensitivity terms, including feature of immediate immune mediated IgE and delayed immune mediated T cell hypersensitivity reactions. So, principles of assessing patients reporting antimicrobial hypersensitivity in dental practice. Clinical history for initial assessment of patients reporting antimicrobial hypersensitivity in dental practice. Clinical history is critically important in the diagnosis of antimicrobial hypersensitivity. If a patient reports having antimicrobial hypersensitivity, which is allergy, we'll see figure 13.6 for questions to ask the patient. The main aim are to evaluate the details of symptoms and signs to distinguish between a hypersensitivity reaction and a predictable drug intolerance. For example, nausea, vomiting, diarrhea, headache, dizziness, itch without rash, fever, or internal organ involvement. We also need to evaluate the severity of the reaction. For example, a severe reaction requiring hospital treatment. Timing to help distinguish between immediate and delayed hypersensitivity reactions. Whether the patient has tolerated the same antimicrobial or an antimicrobial from the same class since the reaction. We also need to evaluate what other antimicrobials the patient may have taken since the reaction in question and how the patient reacted to the other antimicrobials. A family history of antimicrobial allergy does not justify avoidance of the implicated drug. So if the patient say that he has a family history of allergy, it does not justify the avoidance of the implicated drug. Now, figure 3.6, what questions we need to ask patients reporting an antimicrobial allergy in an antimicrobial allergy assessment in dental practice. So, we need to ask the severity and type of reaction. For example, we need to ask the patient, do you remember the details of the reaction? We need to ask, how was the reaction managed? Like, did it require treatment or it required hospitalization? We also need to ask about the timing, like how long after taking the antibiotic did the reaction occur? Or how many years ago did the reaction occur? Also need to ask about antibiotic use since reaction. Like, are there other antibiotics that you have taken without problems since the reaction happened? For an approach to interpreting the history from a patient reporting hypersensitivity to penicillin. We'll see figure number 3.7. So figure number 3.7 is we'll look on it in a detail. Okay. So it was figure 13.7. We'll look on it in a detail. Okay. Now, implication of the clinical history of a reaction to an antimicrobial for dental practice. Communicate any new detail of the clinical history of a drug reaction to the patient's medical practitioner. If the clinical history suggests that the reported reaction is a drug intolerance, for example, gastrointestinal disturbance, rather than a hypersensitivity reaction, direct delabeling of the patient's allergy. That is, removal of a patient's reported antibiotic allergy based on their history alone by a medical practitioner is appropriate. You can't remove by yourself, it has to be done by a medical practitioner. This step assists antimicrobial selection by removing an inappropriate restriction on antimicrobial choice. If the clinical history supports hypersensitivity, the patient's medical practitioner can consider whether allergy testing, for example, using skin prick or oral challenge, and rarely desensitization are appropriate or not. Now, allergy testing should only be performed by someone with expertise in antimicrobial allergy testing with appropriate consultation, consent, medical supervision, and equipment to manage severe allergic reaction. Desensitization, which is an induction of temporary tolerance, is a specialized allergy management strategy that may be considered by medical practitioners for a specific patient. For example, if the patient is with severe immediate IgE mediated hypersensitivity. If a specific antimicrobial is preferred or no alternative antimicrobials are available, desensitization is contraindicated with patient severe delayed hypersensitivity. Okay. In patients whose clinical history supports penicillin hypersensitivity, further assessment and management advice is summarized in 13.7. For management of patient with a history of cephalosporin hypersensitivity, we need to seek expert advice. So for penicillin hypersensitivity, we will see what we have to do. But if the patient has a history of cephalosporin hypersensitivity, we need to seek expert advice. Seek medical advice if unsure of the implication of a possible reaction to any drug for dental prescribing. Now, penicillin hypersensitivity, information for dentist. Assessing patients reporting penicillin hypersensitivity in dental practice. To assess a possible penicillin hypersensitivity reaction, take a thorough clinical history. Then interpret the significance of the history, including whether the reported reaction is a drug intolerance or whether the clinical history supports hypersensitivity. Now, these steps inform decision on managing patients reporting penicillin hypersensitivity. Managing patients reporting penicillin hypersensitivity in dental practice. How we will manage those patients who have penicillin allergies. Now, management of patients reporting penicillin hypersensitivity depends on many factors, including the likelihood of cross-reactivity with a cephalosporin. Consider whether antimicrobial therapy is necessary and the balance of benefits and harms. The figure 13.7, which we'll read it very soon, provides a guide for clinicians to classify penicillin hypersensitivity reaction. Subsequent antibiotic choice is described for patients with immediate severe penicillin hypersensitivity, then immediate non-severe penicillin hypersensitivity, then delayed severe penicillin hypersensitivity, and delayed non-severe penicillin hypersensitivity. The guidance in this topic is a simplified summary of a complex clinical problem. The antibiotic expert group recognizes that there are variations in how penicillin hypersensitivity is managed, and that specialists may choose to manage patients differently after weighing up the balance of benefits and harms in an individual. The likelihood of cross reactivity between penicillin and cephalosporin affects the safety of using certain antimicrobials. Advice on appropriate alternative to penicillin have been provided within drug recommendation in these guidelines. If the nature or severity of a reaction to any penicillin is unclear, despite careful history taking, dental practitioners should consult with the patient's medical practitioner to investigate further. If possible, before prescribing a non-beta lactam, risk of non-beta lactam alternatives, for example, clindamycin, include antibiotic-associated diarrhea and antimicrobial resistance. For management of patient with a history of cephalosporin hypersensitivity, seek expert advice. Now, this is figure 13.7. It's very, very important, and it's very, very easy to memorize what is written in there. So, approach to assessment and management of patients reporting hypersensitivity to penicillin in whom a beta lactam antibiotic is the preferred drug. So, how do you approach and assess and manage the patients which are allergic to penicillin and beta lactam antibiotic is the preferred drug in those patients? What you can do? So, penicillin hypersensitivity reported by a patient in whom a beta lactam antibiotic is the preferred drug. First, we need to obtain an accurate clinical history of the hypersensitivity. Now, it says NB1. We'll read what is NB1 means. For advice on history taking, we already read before what questions we need to ask from the patients. Okay. Now, obtain an accurate clinical history of the hypersensitivity and consider if their allergy can be directly delabeled. Then we need to ask how long after exposure to penicillin did the hypersensitivity occur, just to find out if it was an immediate reaction or it was a delayed reaction. So, immediate IgE mediated penicillin hypersensitivity, it occurs typically within 1 to 2 hours of drug exposure. And delayed, which is T cell mediated penicillin hypersensitivity, it typically occurs days after treatment, but it can occur more rapidly on rechallenging. Okay. Now, after asking about the timing, that how long after exposure to penicillin did the allergy occur, we need to find about the severity. So we need to ask how severe are the symptoms. If the symptoms are severe, for example, airway angioedema, anaphylaxis, compromised airways, or hypotension, or collapse, so those are immediate severe. In this condition, we need to liaise with the medical practitioner so that they can consider allergy testing under specialist supervision where such testing is available. But if the patient has immediate severe hypersensitivity reaction, we need to avoid penicillin, for example, amoxicillin, benzyl penicillin, phenoxymethyl penicillin, and we also need to avoid cephalosporin, for example, cephalexin. Okay, it is safe to administer non-beta lactam antibiotics, for example, clindamycin. For advice on intravenous antibiotic choice in a hospital setting, see the antibiotic guidelines. Okay, that was the severe reaction, immediate severe reaction. Now, what will we do if the patient has immediate non-severe reaction? Now, what are the non-severe reactions are? Mild immediate rash, urticaria, benign childhood rash, maculopapular rashes. So these are all non-severe immediate reactions. In this case, we need to liaise with the medical practitioner so that they can consider whether the patient's allergy can be directly delabeled or whether allergy testing under specialist supervision is appropriate where such testing is available. Again, we need to avoid penicillin, for example, amoxicillin, benzyl penicillin, and phenoxymethyl penicillin. But it is safe to administer cephalosporin, for example, cephalexin, in patients with immediate non-severe penicillin hypersensitivity. We can safely give cephalosporin to the patient. Okay. Now, cephalexin can be used in patients who have had a non-severe immediate or delayed reactions to penicillin, including amoxicillin or ampicillin. However, because cross-reactivity between cephalexin and either amoxicillin or ampicillin is possible, consider the extent of the amoxicillin or ampicillin reaction, patient acceptability, and the suitability of non-beta-lactam options. For advice on intravenous antibiotic choice in a hospital setting, see the antibiotic guideline. Okay. So that was the immediate, severe, and non-severe. Now let's read about delayed T-cell mediated penicillin hypersensitivity. So again, we need to ask how severe are the symptoms? Is it severe or non-severe? So severe includes severe cutaneous adverse reactions. For example, what are the severe cutaneous adverse reaction? Are drug rash with eosinophilia and systemic symptoms, which we call it DRESS, the Stevens-Johnson syndrome, or toxic epidermal necrolysis, 10, severe blistering or desquamative rash. So those are all the severe kind of delayed reactions from penicillin hypersensitivity. What you're going to do with this? We need to avoid penicillin, for example, amoxicillin, benzyl penicillin, phenoxymethyl penicillin. We also need to avoid cephalosporin, for example, cephalexin. We also need to avoid penicillin desensitization in these patients because they have a delayed severe penicillin hypersensitivity. It is safe to administer non-beta-lactam antibiotics, for example, clindamycin. For advice on intravenous antibiotic choice in hospital settings, see the antibiotic guidelines. Now, if the patient has non-severe delayed penicillin hypersensitivity, we need to liaise with a medical practitioner so that they can consider whether the patient allergy can be directly delabeled or whether allergy testing under specialist supervision is appropriate, where such testing is available. Avoid penicillin, for example, amoxicillin, benzyl penicillin, phenoxymethyl penicillin. It is safe to administer cephalosporin, cephalexin. For advice on intravenous antibiotic choice in a hospital setting, see the antibiotic guidelines. So about this whole table, we found out that there are two different kind of penicillin hypersensitivity. First is immediate and then delayed. So immediate occurs within 1 to 2 hours, and delayed occurs days after the treatment. Then further, we need to divide the immediate into severe and non-severe, and delayed also severe and non-severe. If the patient has severe, even in immediate or delayed, we need to avoid penicillin and cephalosporin at any cost. And it is safe to administer clindamycin. In non-severe, as it says, that if it's non-severe reactions, immediate or delayed, we need to liaise with the medical practitioner so that they can consider whether the patient allergy can be directly delabeled. And we also need to avoid penicillin, all kind of penicillin. It is safe to administer cephalosporin, but again, they have put a note at the bottom of the page that cephalexin may be used in patients who have had a non-severe reactions. However, cross-reactivity can occur. So we need to consider patients' acceptability and the suitability of non-beta lactam. So in any case, I think either if they have hypersensitivity delayed or immediate, we need to avoid, and it's just safe to administer clindamycin. Don't give any penicillin or cephalosporin if the patient if the question is coming in the exam. Okay, now approach to assessment and management of patients reporting hypersensitivity to penicillin in whom a beta-lactam antibiotic is the preferred drug. This is all the same, which we have read previously in figure number 13.7. So they have divided all these in different things, but I can read it for you. So penicillin hypersensitivity reported by a patient in whom a beta-lactam antibiotic is the preferred drug. Obtain an accurate clinical history of the hypersensitivity and consider if their allergy can be redirectly delabeled. We need to ask how long after exposure to penicillin did the hypersensitivity occur to find out if it's immediate or delayed. So immediate occurs within 1 to 2 hours of drug exposure. Delayed occurs after starting treatment, days after starting treatment, but can occur more rapidly on rechallenging. Then we need to ask how severe are the symptoms, whether they were severe or non-severe. So if they are severe, for example, anaphylaxis, compromised airway, angioedema, hypotension, collapse, we need to stop penicillin and cephalosporin, and it is safe to give clindamycin to the patient. Similarly, in non-severe, it says see immediate non-severe penicillin hypersensitivity, which we already discussed about it. On this figure 13.8, antibiotic choice in dental practice for community-based patients with an immediate severe penicillin hypersensitivity. So lies with the medical practitioner so that they can consider allergy testing under specialist supervision where such testing is available. Avoid penicillin, for example, amoxicillin, benzyl penicillin, phenoxymethyl penicillin. And we need to avoid cephalosporin also, and safe to administer non-beta lactam antibiotic, for example, clindamycin. In 13.9 also, they have said the same thing. Antibiotic choice in dental practice for community-based patient with an immediate non-severe penicillin hypersensitivity. So lies with the medical practitioner so that they can consider whether the patient allergy can be directly delabeled or whether allergy testing under specialist supervision is appropriate. In this case, also avoid penicillin, safe to administer cephalosporin. And again, they have said that cephalexin may be used in patients who have had a non-severe, immediate or delayed reaction to penicillin, including amoxicillin or ampicillin. However, because cross-reactivity between cephalexin and other amoxicillin or ampicillin is possible, consider the extent of the amoxicillin or ampicillin reaction, patient acceptability, and the suitability of non-beta lactam options, for example, clindamycin. 13.10 is giving points about the delayed severe penicillin. So in this, we need to avoid if the patient has delayed severe penicillin hypersensitivity, for example, severe drug rash with eosinophilia and systemic symptoms, Stevens-Johnson syndrome, toxic epidermal necrolysis, severe blistering or desquamative rashes, and significant internal organ involvement, for example, acute interstitial nephritis. So in these conditions, we need to avoid penicillin, cephalosporin, and also penicillin desensitization. We can't go for that if the patient has delayed severe penicillin hypersensitivity. And it is safe to administer non-beta lactam antibiotics, which is clindamycin. Figure 13.11 is giving points about delayed non-severe penicillin hypersensitivity. It says lies with the medical practitioner so that they can consider whether the patient's allergy can be directly delabeled or whether allergy testing under specialist supervision is appropriate. where such testing is available. So avoid penicillin, safe to administer cephalosporin, and cephalexin may be used, but there is a chances of cross-reactivity. So we need to consider the extent of the amoxicillin or ampicillin reaction, patient acceptability, and the suitability of non-beta lactam options, for example, clindamycin. Now, let's read about cross-reactivity between penicillin and cephalosporin. What are the information for dentists, for us? The prevalence of cross-reactivity between beta-lactam is not known precisely. It is a common misconception that cephalosporin allergy occurs in approximately 10% of patients who are allergic to a penicillin. Immune-mediated penicillin hypersensitivity was historically thought to be due solely to the beta-lactam ring structure that is common to all beta-lactam antibiotics. For example, penicillin, cephalosporin, carbapenems, and monobactams. However, clinical data show that most reactions occur in response to antigenic molecules in the R1 side chains that distinguishes individual penicillin and cephalosporin from one another. So there is actually R1 side chains which distinguish between penicillin and cephalosporin. The cross reactions are uncommon unless drugs share the same or similar R1 side chains. So if two drugs have similar R1 side chains, only then cross reactions are occur. For example of drugs with identical or similar R1 side chains, we will see in the table 13.3. Recent evidence suggests that less than 1.5% of patients with a confirmed penicillin allergies have a cephalosporin allergy. This rate is similar to the incidence of new drug allergies or reactions to structurally dissimilar medication in patients with prior drug allergies. Now, the American Academy of Allergy, Asthma, and Immunology, which is AAAAI, and the American College of Allergy, Asthma, and Immunology practice parameter update suggest around 2% of patients with a confirmed penicillin allergy will experience a reaction to a cephalosporin. Only 2% of patients with a confirmed penicillin allergy will experience a reaction to cephalosporin. It also suggests that less than 5% of patients with an unconfirmed penicillin allergy are truly allergic. When patients with an unconfirmed penicillin allergy are given cephalosporins, the chance of the reaction is very low, with a probability of around 0.1%. So that is too low. The permissibility of cephalosporin in patients with penicillin hypersensitivity depends on the type of allergy. Either it is non-severe, immediate, or delayed hypersensitivity, or it's severe immediate hypersensitivity. Also consider the similarity of the beta-lactam R1 side chains, or it's a severe delayed hypersensitivity. For definitions of the type of hypersensitivity, see definition of commonly used antimicrobial hypersensitivity terms. Advice on appropriate alternatives to penicillin is also provided within drug recommendation in these guidelines. Now in this table, they have given the examples of beta-lactam antibiotic with similar or identical R1 side chains. So there are antibiotics name and then antibiotics with a similar or identical R1 side chains. So antibiotic name amoxicillin and ampicillin, they have similar or identical R1 side chains with as cephalexin or cefaclor. Similarly, if cefaclor, they have a similar R1 side chains as amoxicillin, ampicillin, and cephalexin. And if there is a cephalexin, they have similar R1 side chains as amoxicillin, ampicillin, and cefaclor. Cefazolin has, up till now, they have no similar or identical R1 side chains with any antibiotic. Cefuroxime cefuroxime. They have similar R1 identical side chains as cefepime, ceftriaxone, cefotaxime, and ceftazidime. Okay. Cefepime have cefuroxime and ceftriaxone. Similarly, ceftriaxone have similar R1 side chains as cefuroxime, cefepime, and cefotaxime. Cefotaxime has similar R1 side chains as cefuroxime, cefepime, and ceftriaxone. And ceftazidime have similar R1 side chains as cefuroxime and aztreonam. So, non-severe, immediate, or delayed hypersensitivity information for dentists on implication of cross-reactivity between penicillin and cephalosporin. They say cephalosporin are safe to administer to patients with non-severe, immediate, or delayed penicillin hypersensitivity. Although cephalexin and aminocephalosporin contains a similar R1 side chains to aminopenicillin, that is amoxicillin and ampicillin, it can still be administered in patients with non-severe, immediate, or delayed hypersensitivity to penicillin, including amoxicillin or ampicillin. However, because cross-reactivity between cephalexin and either amoxicillin or ampicillin is possible, consider the extent of the amoxicillin or ampicillin reaction, patient acceptability, and the suitability of non-beta-lactam options, for example, clindamycin. Now, severe immediate hypersensitivity information for dentists on implication of cross-reactivity between penicillin and cephalosporin. For patients with severe immediate penicillin hypersensitivity in community dental practice, avoid all penicillin and cephalosporin. Although cross-reactivity is generally unlikely, it is more challenging to manage a severe immediate hypersensitivity reaction in the community than in the hospital, where resuscitation facilities are more readily available. A non-beta lactam is the recommended alternative. Okay. Now, avoid prescribing any cephalosporin in the community to a patient with immediate severe penicillin hypersensitivity. In a hospital setting, antibiotics that do not share the same or similar R1 side chains to penicillin, for example, cefazolin, are considered safe to administer to patients with severe immediate hypersensitivity to penicillin. Provided certain factors are considered, see severe immediate hypersensitivity implication of cross-reactivity between penicillin and cephalosporin in the antibiotic guidelines. So these are for the medical practitioners because it's in the hospital setting. In contrast, the aminocephalosporin, cephalexin, and cefaclor share the same or similar R1 side chains with the aminopenicillin, amoxicillin, and ampicillin, so should not be administered to a patient with a severe immediate hypersensitivity to amoxicillin or ampicillin. Most cross-reactivity reported in the literature is between aminopenicillin and aminocephalosporin. Rates of cross-reactivity between drugs that do not share a similar R1 side chains are exceeding low. So cephalexin or cefaclor should not be administered to a patient with severe immediate hypersensitivity to amoxicillin or ampicillin because of their similar R1 side chains. So at the end, they have said that cephalexin or cefaclor, which are cephalosporins, if the patient has severe immediate hypersensitivity to amoxicillin or ampicillin, we should not give them cephalosporin also because they share similar R1 side chains. Now, severe delayed hypersensitivity information for dentists on implication of cross-reactivity between penicillin and cephalosporin. In this condition, we need to avoid all penicillin and cephalosporin in patients with severe delayed penicillin hypersensitivity. For example, drug rash with eosinophilia and systemic symptoms, Steven-Johnson syndrome, toxic epidermal necrosis, severe blistering or desquamative rash, significant internal organ involvement, for example, acute interstitial nephritis. We need to avoid all penicillin and cephalosporins in patients with severe delayed penicillin hypersensitivity. Cross-reactivity between penicillin and cephalosporin is less well described in patients with severe delayed penicillin hypersensitivity than in those with immediate hypersensitivity. Rarely, patient may be allergic to the beta-lactam ring structure common to all penicillin and cephalosporin and not the R1 side chains, which vary between drugs. Okay, so here we ended about the cross reactivity and about the hypersensitivity. Next, we will read about practical information on using antimicrobial drugs in dental practice. And that's the end of today's chapter. Remember, small steps every day bring you closer to your goal. If you are preparing for the ADC exam, don't forget to subscribe and share this channel with your friends and study group. Together, we'll make TG easier, clearer, and stress-free. Your ADC success starts here. Bye for now.